health economics is quite a broad area of work, but basically what health economics tries to do is to tackle the issue of getting the best outcomes for patients in the most efficient way with limited resources. Some of the things health economists do is evidence-based review. We are always hungry for evidence, and we also generate that evidence. The way to generate the evidence is by pulling together really good data and undertaking complex analysis that takes the form of econometric modeling and Markov models. To do really good population health analysis, you need what is called outcome variables or data that reflects outcomes from patients. You need demographic data, and you need some markers of utilization and cost and other type of data from many services. So the really good thing to be doing if we are serious about doing population health analysis, linking that data. A lot of people are interested in what's going to happen, whether demand is going to go up or is going to decline. And I use certain techniques, which is particularly called ARIMA modeling. I can use other pieces, but ARIMA is kind of the gold standard to actually predict how a trend is going to behave. And if you think about a trend have an upwards or downward component, and have also what is called a business cycle, things that goes up and down, and a seasonal component. So what I do is, with equations, I pick up all those elements and build an estimation of, based on that, what is going to happen. So the health economics, especially the tools and rigor around it, is a really good vehicle to make the case for change. I recently worked in a project that where a group of people wanted to set up a clinic to detect a rare genetic disorder that is quite prevalent, and there's nothing in place locally. But obviously there is a resource implication. So what I help is what I did. I supported commissioners, and I worked very closely with the consultants to actually understand how that setting up that clinic was going to help patients' outcomes, and what sort of finance impact that was going to have. So I model all the data, all the pathway, the people coming in the service, how much that was going to cost, using some productivity metrics around how many patients the service was going to see based on another evidence from other clinics around the country, and from articles and reviews that I could tap into, and experts in the area, and we could finally make the case for change, where we could say how many lives we were going to save in 5 years, how many cardiovascular episodes were going to, or called adverse events, going to be presented. The potential is immense because commissioning is moving at fast pace, resources are very limited, and transformation is required. So if we bring that rigor that health economics bring into the commissioning environment, that's where we can add more value. So you look at effectiveness of a certain intervention and what's kind of how efficient that can be done with limited resources. We are really in that environment in a commissioning scenario where lots of savings need to be made, and those savings need to be quantified adequately. It can't be just done with summation and multiplication. It needs to be done very regularly. So this is a really good moment, and Arden GEM is really innovative in bringing health economics into the transformation projects, into population health analytics.